So let's move over to today's clinical topic. And our speaker is Dr. Taylor Manalili. She received a degree in chemical engineering from Northeastern University and then went to Stony Brook University, where she earned her dental degree as well as her specialty certificate in prosthodontics. She's a full-time clinical prosthodontist at Glidewell. She's a key part of our team here, provides valuable input to our training and education programs and all kinds of programs throughout the lab. Today, she'll be giving us an update on the single unit implant and talking about the state of the art for both analog and digital workflows. So here is Dr. Taylor Manalili.
Thank you so much. It's good to be back here. It's been a while since I've been here. Just give me a moment while I share my screen. All right. Well, thank you guys for tuning in today. Happy Friday. I also went on vacation about a week ago, back to New York, where I'm from, and it was so lovely to take a little time off. So I'm with you, Brad. I like a little summer vacation. Okay, so today I chose to talk about the single unit implant. And I chose this because this is primarily what a lot of us do in our practice, right? In the future, we'll talk about, maybe we'll expand on this and talk about multiple units and then full arches. But for now, I think this is on an everyday basis, typically what a lot of us do in our practice. And like Dr. Park mentioned, I do work here at Glidewell. And so I get to, I see patients just like you guys, but I also get to work pretty intimately with the different departments here. And I get to see a lot of the work that comes in, and I get to see a lot of the struggles that we all have in our practice, and I try to help work through some of those problems. And so today I really want to present to you kind of what your options are, right? So what your options are for restoring a single unit implant, kind of walk you through each of these workflows, and really what are some of the things that maybe you can help to do before you take your impressions, or while you're thinking about starting one of these cases, to help you kind of be successful in seating that restoration on the first go around. And then the most important part is how we seat these, right? So seating these for success. All right. So in general, I just want to walk through and talk about, let's see if this forwards through. Walk through and talk about kind of what our options are when we have a single unit implant. And so in the future, I'll kind of talk about why some of these options as of right now and today, we may not want to use when we deal with multiple implants or full arch implants. But for the single unit implant, these are really all acceptable options. Okay, so we have our kind of various impression copings that you see in front of you, and they're really used to help transfer the position, the angulation, and the connection, the internal connection of the implant, that orientation to the laboratory. So one thing you'll notice on all four of these images is you'll see they have that engaging component. And so you'll see here, if you can see my mouse, I'm not sure, but on the lower portion of all of these impression components is this engaging component, and that helps show the lab the orientation of your implant. And so it's really important, if your implant system that you're using has an impression coping that is engaging, that especially for single unit implants, you utilize that component, okay? So if you're not familiar with different terms, they could be called different things. So I always like to point that out depending on the system. They could be called, if you're ordering these yourself, they could be called impression posts, direct pickups, indirect pickups, depending on what you want, right? Closed or open, transfer coping, scan bodies. There's a lot of different terms out there. So make sure whatever system you're using, you understand what you're looking up. Especially now everything is online. I know when we search certain terms, they don't always pop up directly in the catalog. So understanding that is really important. Evaluating the patient themselves. So these come in different lengths, different widths. So understand where you're taking an impression in the mouth, like how wide you want the impression coping to be, how tall you might want it. So not everyone can open like an alligator, like we wish they could. And a lot of companies are really lovely and they actually color code these. So it's really nice. You can see from the cover screw through the healing abutment, through the impression coping, they're all color coded. So it's really nice and easy to identify. Other systems are not so nice and it takes a little longer to figure it out. Okay, so when we look at these, what are the main differences? So we have, I'm going to start with the closed tray. So this is also known as the indirect pickup impression. And this really, when you take this, if you look at the tray, so this is a stock tray we're using, right? You can see that I didn't actually create any holes in the tray. So that's why we call it a closed tray, right? So we're not cutting into the tray at all. And this is attached directly to the implant. You're basically gonna, you notice kind of these vertical indentations on these, and those really help just realign the impression with the coping after the impression is made. So this is more for an alignment purpose, right, on the laboratory side. But the big thing with these is these stay in the mouth throughout the impression process. And even when you remove the impression tray, these copings stay in the mouth. Okay, hence why we have these closed tray impressions where we don't have to mess with this. So again, these typically have kind of a tapered look to them. They have more of a smooth shape, so the impression material can easily slide off around it once it's set, very similar to, say, a tooth prep, right? So a little taller than most of our teeth prep, but very, very similar concept, okay? Versus an open tray impression coping. So here we see we've cut this nice hole inside the tray or into the tray, and you actually see the coping coming through the tray. Right. So this is my preference. Everyone has their own preferences. I personally love to do this. Studies have shown for single unit implants, either technique is perfectly acceptable. I personally like when I take my impressions, I like to not mess with taking a coping in and out of the impression material. So with an open tray, you'll kind of see it has a much more aggressive pattern around it, right? So it has a lot more indentations. It doesn't have those nice vertical slats, that nice tapering look like the closed tray did. It has much more undercuts to it. And that's on purpose, right? We want the impression material to grab in and around that impression coping. And because when we do take the impression out of the patient's mouth, the coping comes with it. Right, so we'll go ahead and we'll unscrew the coping, and the coping and the impression tray come out as one piece. And so again, I like this technique because I'm not worrying about deforming the impression material at all when I take the coping in and out. There's always a slight chance for that. Again, studies have shown for single units, you can really do either. At this point, it's just personal preference. Wow, this looks really blurry here. I'm so sorry. But this is a press fit coping. Okay, so a press fit coping is really held in place with mostly friction. So held in place with friction instead of a screw like the others. The other two are screwed into place. This is held with just friction. So it's basically just like it seems. You press it into place or snap it into place. Some companies have them, they call them like snappy abutments, right? So these snap into place. And they basically behave kind of like your closed tray impression coping. So they have your open tray impression coping. I'm so sorry. So they have all of those undercuts in them. And basically when you pull the impression out, these also snap off the implant and stay embedded inside that impression material. So positives and negatives of this, right? So they're really easy to place. However, they can be kind of unstable, right? Because you're pressing them in. There's nothing really securing and locking them in place. So you can accidentally hit them with the impression tray. If the patient has a really aggressive tongue, a lot of times they'll push these out or just a little bit and you don't realize they push it. So you might get a little inaccurate impression from that. And so a lot of times also the material of these is not such, I'm going to talk about this in a little while, but I do like to take a radiographic confirmation that all of my impression copings are seated. This material, typically these are made of some sort of plastic material and you can't take an x-ray. So you don't really know if they are seated. And even if you do confirm, a lot of times they can be bumped or moved with instrument, patient, whatever it is. So I do tend to stay away from these in most situations. The one benefit of this is if the patient has a really kind of narrow opening, sometimes these are helpful because you don't need to get an implant driver in there. But again, that's a very, very rare situation. Typically, if they have an implant, you can get one of the other impression copings in there. If they were able to drill and place the implant, you're probably able to do this. So again, a very, very rare situation that I'm utilizing something like this. Okay, the last of the impression choices would be your scan body itself. And so scan bodies we use for digital impressions. So the rest are for analog. This is for your digital impression. And every company has their own version of a scan body. But the basic breakdown of a scan body, when we look at it, there is some sort of geometrical pattern on the scan body. And we call this kind of the scan region. And this region basically has a library. So for now, I think at this point, a lot of us are familiar with digital workflows and how different digital libraries work. But basically, every implant system has its own, we call it a library, that gives the laboratory an idea of what the orientation and virtual placement of that implant is. And so it's really important that the implant coping, the impression coping or scan body is seated correctly, right? Correctly in that orientation. And that you capture that geometry of that impression coping or scan body perfectly. So we don't want to miss any of that geometry. There's other parts, right? So there's the body. I still like to capture that. It's not as important. If I'm missing like a little section of the body, I'm not wasting my time scanning over and over and over again to get that. But I do like to capture as much of the scan body as I can. And then the last section is the base. And this is just like the others. This engages into the implant itself, giving the lab the orientation of the implant. All right. So I promised you guys I'd talk about how we avoid some of the complications, especially the ones that I see a lot in the lab. So a big part of any implant impression or placing implants for that matter is really evaluating the patient, evaluating the situation, right? Every situation is very different. That's the beauty of dentistry and why I love it so much. It's predictable and unpredictable all at the same time, right? So we have here, before we take our impression, we always want to sit and evaluate the situation. So this patient presented, we had to do stage 2, right? So we removed soft tissue. And this is a complication a lot of us fall into, right? We don't really pay attention to, especially if the implant looks like it's integrated. We don't really pay so much attention to the soft and hard tissue at this point, right? So I highly urge you, if you are placing your own implants yourself, you want to evaluate all this stuff, obviously, before the implant goes in, but then again at the restorative phase. If you are strictly the restorative doctor, look at it. Make sure that the surgeon paid attention to everything they should have paid attention to. Inform the patient right off the bat of certain things that might lead to future complications, so you're not really responsible for it in the future. They can take some ownership in it as well. Okay, so when we go to uncover, one of the common complications we run across with a lot of times is that we have some hard tissue that fell over that implant or grew over top of that implant. A lot of times this bone is really, really thin. You can kind of see some of that bone there on the left-hand side of the screen. So we uncovered the soft tissue, but there's a little bit of bone left, depending on what you have in your office. So I like to utilize, when something like this, it's really soft bone, really easy to get off. So I'll typically use some sort of chisel or like a curette to basically just remove a little bit of that bone on top of the cover screw. And then I'm able to remove the cover screw, right? And then place my healing abutment if I wish to, or place my impression coping if I decide to do that right off the bat. Another thing I want you guys to start to pay attention to, though, is the actual emergence profile of the implant, of like the restorative emergence coming out of that implant. So sometimes we're able to get the cover screw on, we're even able to put the healing abutment in, But then we got to think about what we want the shape of the restoration to be. So sometimes we need to take away a little bit more bone. A lot of these implants now we see like this great bone growth around and over the top of this, which is wonderful. But sometimes it's too much, right? So sometimes I do want to take away a little bit more. So what you see here, these are actually a version of a bone profiler. So there's several different versions out there on the market. But basically what a profiler does is it protects the platform, the restorative platform of the implant. And it has these aggressive threads around the edge of it, and it helps to remove excess bone. Basically, you place it on and you twist it, and it'll basically just remove that bone around your restorative platform. So a lot of implant systems have their own. There are some generics that come in just various sizes that you can order. But this is really, really nice. And if you restore a lot of implants, I highly recommend getting yourself some bone profilers to help you really remove any excess bone that might be in your way when it comes time to restore. And so I do see this a lot as one of the biggest complications. When doctors say their restorations don't fit, they'll send me x-rays and I see, yes, it might be a little over contoured from the laboratory, but also there is some bony overgrowth that will really prevent the lab from creating a properly contoured restoration for you. Okay. So another complication I see a lot is evaluating the path of insertion, right? And so this is hard, right? RPDs were like I'm a pros, and RPDs are like one of my least favorite things to do, right? Because you got to make those perfectly good guide planes. Everything has to fit just so, right? So implant restorations in between teeth, single units, this is a challenging part. Right. So I love to see, I'll talk about this in a little bit. We have this trend among all of us that we're moving towards screw retained restorations, which is wonderful for the patient, wonderful for us, maintenance wise, easier for us to insert, sort of. Right. I'll get to that in a second. And then, yeah, it's just long term complication wise, you just don't see the complications we once saw. But to do a screw retained restoration, this is one of the biggest things you guys really have to pay attention to. And so I'm sure all of us have had it. I'm guilty of it. We take an impression, we send it to the laboratory, and then they send it back, and I can't figure out how to insert it, right? It doesn't really seem to fit between those adjacent teeth. And a big part of that is because we haven't properly evaluated that path of insertion in relationship to the implant. If you've been doing this for a long time, maybe you used to do a lot more cement retained restorations, and it's a little easier, right? It's kind of more like a natural tooth. You put in your abutment first, which engages into the implant, and then from there, the laboratory can play with that path of insertion based on what the adjacent teeth look like. But when you have a screw retained situation, it's all in one, right? So you have to get the path of insertion into this implant as well as the adjacent teeth. And that can be more challenging than we think it is. So whenever I am evaluating before I take my impression, I take a few minutes. This doesn't take long now, but just take a couple seconds to evaluate. So I always want to evaluate for a few things. And if you've seen me lecture on something similar, I've probably gone over this, but it's so important to understand, right? So one of the things, this is all over the literature, is long-term issues we have with single unit implants in between adjacent natural teeth is this recurrent caries area, right? So right where these blue circles are in these black triangle areas, patients got themselves in this situation where they lost a tooth, most likely for a reason. And it probably wasn't because they had perfect oral hygiene, right? So we want to give them the benefit of the doubt and make sure we give them the best situation we possibly can. So I always like to evaluate these adjacent areas and make sure I'm not going to give them these giant black triangles that they're going to have a really hard time keeping clean. Okay, so when you see something like this, these giant undercuts, it's a risk for food impaction, black triangle formation in the future. caries, periodontal issues, not necessarily just around the implant, but around those adjacent teeth as well. Okay. And then I also, when I look at this, I see just complications coming my way when it comes time to just deliver the prosthesis, right? So, what am I looking to do? So, I talk about this to my patient, right? Because I don't want to enamelplasty something without informing them of what's going on. And generally, whenever I talk about doing a single unit implant, I always talk to them about the possibility of having to do this. So I always say, I want to make everything ideal. We want to make sure we have nice contacts. We want to make sure I'm not creating any food traps for you. So whether you decide to add a little composite to the adjacent teeth, recontour the adjacent teeth by taking away or adding, however you like to do it, I just like to eliminate as much of those black triangles as possible for the patient. So when we look at this, we can see the path of insertion of the implant. So you can use the impression coping of your choice. If you have a system that you place and use in your office a lot, you can invest and buy a few, they call them guide pins, that are just long, skinny screws that can screw into the implant itself, and it'll show you what that access, that long axis of the implant looks like. And then you can take your mirror and really evaluate the adjacent contact areas, right? Those proximal areas. And so what I really want to do is create guide planes that are parallel to the long axis of the implant. And that's going to make for a really easy time for me to insert that restoration. And so this might be way too aggressive for you. And, we do a combination of taking away and adding, like I said, depending on how much those undercuts are and how much of the soft tissue has gone away, right? So ultimately, we just want to make it cleansable for the patient. So we're going to go ahead and I want to recontour a little bit, creating some guide planes for the patient. One of the things I want to point out, you'll notice there is a healing abutment here. So if there is limited space, this also makes it a little challenging, right? We got to visualize. If there's limited space, you want to make sure you're not going to damage your impression coping. So if it's a closed or an open tray conventional impression coping, analog impression coping, less worried about it. In the digital world, you really don't want to alter your impression copings or scan bodies at all. Right. So those libraries are very specific to the shapes of those implants. If you start altering the shape of the scan body in any way, it makes it really hard for the lab to figure out how to read that impression. Okay. So here we take the scan body out, we replane those guide planes, and then we go ahead and put our scan body back in. So another thing I want you guys to get in the habit of doing, because we see this a lot coming through, is evaluating the opposing. So evaluate it before you take your impression. So go ahead, place your, with the cover screw in, take a quick peek at how much room you have. Okay, we can do a lot of miracles now with the lab. I've seen some really tiny, tiny crowns, but it's not super aesthetic. It's not the most functional thing for the patient. And over time, when you have this super erupted tooth that's constantly putting excess forces on that opposing restoration, you're going to do damage to that restoration and that implant over time. Hopefully, it's just the restoration and not the implant. But down the road, we could see some issues with the implant. So go ahead. I never like this to be a oh no situation. So I always try to evaluate this while I'm treatment planning and have that conversation with the patient. In a digital world now, it's really easy to see. So if you have an intraoral scanner in your office, take a quick scan of the patient when you're evaluating. I do this now. I show the patient the scan as I'm treatment planning so they can visualize what I see. It's much easier to the patient. Right. And when you do this, it's easier for you to pick up on situations like this. All right. So if it's just a little bit, I'll talk to them about possibly doing an enamelplasty. If it's a lot, we might have to do a new restoration or talk to them about maybe ortho. There's a lot of options out there, right? But we want to make sure we're not leaving the patient in a situation like this if we can help it. So the other thing I want you to take a look at is opposing dentition with what does the anatomy of that dentition look like? So we really want to avoid any beautiful cuspal, like 30, 40 degree cuspal inclinations opposing our implant restoration. So over time, again, this puts a lot of undue off axial forces on that implant restoration and onto that patient. So I might do a little enamelplasty on the opposing tooth, and I talk to the patient about that again during that treatment phase. Okay, a big thing you guys need to look out for is soft tissue, the amount of soft tissue, specifically keratinized tissue. This is a really, really important thing. We've been talking about this for a long time now in the literature, on stage. If you've gone to any meetings in recent years, I'm sure you've heard of this. But we want a nice thick band of keratinized tissue around our implants. If we don't, we want to do some soft tissue grafting. All right. If we don't, it's going to create some discomfort, some bleeding, some issues in the future for the patient. If it's not immediate, they will come back and within a few years to have some issues, and you'll have to deal with it then. So again, this is something the surgeon, hopefully at the time you place the implants, you talk about this and you try to establish that. But as the restorative doctor, I also like to look at this because I don't want to touch the area and then be in trouble because they're uncomfortable with the restoration, not because of the restoration, but because of the soft tissue. Okay, so pay attention to that as well. Also take a look at any frenum attachments now. So, tissue is always this issue. When you go ahead and place your implants and put your restorations on there over time, they have really strong frenum attachments. They're going to pull back on that tissue and you're going to get some recession in those areas. So pay attention to that as well. Okay, so now everything is good. We've talked to our patient. We're ready to take our impression. We put our impression post in. We've contoured our adjacent teeth and we are ready to do this. But the one thing I recommend doing is taking an x-ray. So I mentioned early on in the beginning, I don't like to use those press fit, those friction fit impression copings. And besides them being unstable, a big reason is I can't confirm that they're seated, right? So I do like to confirm that my impression coping is seated with a radiograph. So when you take this radiograph, it's recommended to do some sort of vertical bite wing. So you want to see from that perpendicular standpoint. I don't want any sort of crazy angulation, so I try to avoid a PA if possible. I like to take a vertical bite wing. And coming from this angle, it's really important to understand what the implant connection should look like, right? And for a lot of us, that's hard. We don't always know, but you want to make sure that there's no hard. So here you see some hard tissue here, and this happens a lot. I see this a lot with some dentists. They're able to get the cover screw off. They think they're able to put the impression coping in. They take their impression, but they don't realize the impression coping is actually not fully seated. There's a little bit of bone still in the way. So we want to make sure, we talked about this earlier, using those bone profilers to remove some of that bone, and then you can fully seat your implant. Here, I just put this slide up here because I thought it was nice, but it's a good visual. So every implant system that you have, the components come together slightly differently. So take a look at how those components come together for you. Make sure that they are seating the way you think they should seat, okay? So you can take an implant analog with your impression coping. If it's a new system for you, you can try to figure out how those components should fit together. Okay. But ultimately, knowing what that looks like outside the mouth can help you really identify if that coping is fully seated in your x-ray. Okay. But you shouldn't really see any gaps. And that's the one thing you can kind of see through and through here with all of this in this top row, that these are all fully seated down. Right. And so here on this one, really important to understand how those come together. Right. So pay attention to whatever system you're using. Okay, so now we know fully seated. We've confirmed that. Now we're ready to take our impression. Okay, so there's do's and don'ts for our impressions. And so I want to just say when we are taking our open tray, cut a nice little hole in the tray. One of the things I love to do now, I put a little blue wax. I personally like blue periphery wax. So this is periphery wax that I use on covering this hole. And I like this wax because it's not super sticky, but it's sticky enough that it doesn't pop off. And this just allows, it does two things. It keeps the impression material in, so it's really easy for me to find the top of my impression coping. And it helps me to expose that coping, right? So it keeps that material away. And then while the material is setting, I'm still able to go in and find the top of that coping. Very, very easily let it all set, and then I'm able to take it out. Another thing you can consider doing with conventional impressions, right? So these are conventional techniques, is if you have customized a site, say in the anterior, you've taken the time to customize your provisional or your healing abutment, you can customize your analog impression coping. Okay, so here you see I've added composite to this. And then we go ahead and in the actual impression, you can see on the upper here, you can see we actually have the nice contours, the subgingival contours in the actual, so this is composite resin that I've used to help customize this. You can see that's nice and stable in there. And the reason I like to do this is because over time, think of how long it takes for that impression material to set, and think of how quickly sometimes our soft tissue collapses. So it's just a matter of some patients, it's seconds that the tissue collapses, right? Others, it takes a little longer, but having this tissue pushed to where it should be pushed, and then you can absolutely capture that in your analog impression. So how do I create these? If it's a patient that soft tissue collapses very quickly, I can use the provisional. This is an implant analog. I attach the two, I seat it in a little bit of lab putty so it's nice and hard. And then I take the crown, the provisional off or custom healing abutment off. I place my analog impression in, and I pour my material around it so it looks something like this when it comes out. So it's very, very similar profile. And then I go ahead and take my impression. All right, so let's talk a little bit about digital impressions. So do's and don'ts of digital. Biggest thing to do is when we have our beautifully contoured soft tissue, yes, we can still do this and capture this in a digital format. So one of the things that I like to do is if you've contoured the tissue, you want to capture that soft tissue contour the moment you take your nice provisional off. So I do this actually during the arch scan. Okay, so I know it's not as high resolution as, say, the prep scan, but that's okay. All right, so I still do this during the arch scan. I take my provisional out and I scan this area right off the bat and lock it. Okay, so a lot of scanners now you can lock certain areas. I lock that area. So if the soft tissue does start to collapse, if I accidentally go over that site again, I'm not worried about getting new information. Another big thing here that I would like to say with digital is while you are in this position, there's nothing in your way. Capture your adjacent contact areas. Okay, you have all the access in the world to them. Make your life easier. Capture those adjacent contact areas at this point in time when nothing is in your way. Okay, and then from there, you can go ahead and capture the rest of the arch. If you are in the anterior, so one of the things that I've noticed and I've read and other colleagues have seen the same thing is just to be aware of when you are scanning soft tissue without anything there, notice I have a retractor in here. So I have an obtrugate in this anterior area. If you don't use retractors, have your assistant retract this area. So sometimes what will happen when we're scanning and when we remove a provisional is the lip can actually aid in the collapse of the soft tissue. So if the lip falls into that area, sometimes the soft tissue can collapse a little faster. So I do like to keep that lip away from the area. All right, so these are just some things I've seen come through the lab. They send them to me sometimes so I can evaluate and look. But when we are going through and scanning some of these, we want to make sure we're looking at this quality of our scans. So digital is such an amazing improvement to our lives, right? Digital technology has made everything easier. But that also means you might be able to do more, but you still need to know how to evaluate your scans, right? So all of us, when we were in school, we were taught extensively how to evaluate our analog impressions, but the same thing needs to be done for our digital impressions. So a lot of reps, our rep even came in and told us, right? So they'll come in and they'll say, this scanner has this wonderful autofill feature, or when you click for it to process, whatever is missing, it will fill in and process perfectly for you. Be very careful of doing that in critical areas. Okay, so what happens is if this was an auto-filled area that went to the lab, and you can see on the right-hand side, you can see on both sides, right? It's not perfect. And so that is what? That is your contact area. The chances of that restoration actually seating for me without significant adjustment is going to be pretty low. Okay, so take a moment. It will save you a lot of frustration on your delivery day. Take a moment to just evaluate the critical areas of your scan. Okay, so this is one. Evaluate that quality. You don't want to see any rough surfaces. You don't want to see any missing data. So this is what I want to see instead. I want to see nice, smooth surfaces. If you have saliva, if you have biofilm on those adjacent teeth, it'll show up as grainy surfaces on your scan. Go ahead, take a curette, clean off those adjacent teeth, take your air water, rinse and dry those areas really well before you scan. That will help improve the quality of your scan immensely. Okay. The other thing is you want to make sure that you are capturing the actual geometry of the impression coping. Okay, so the geometry of that impression coping, really, really important. So we have here we have an example of scans that were sent in. So there's really, like I said before, these are libraries. So you want to make sure that these libraries are being met, that they can follow them. If you're missing the geometry, there's no way they can pair them over. Okay, so they basically have a similar shape in the that's what's in the library, and they basically have to match the shapes. So if they don't have a shape to match it to, they don't know where your implant is in space. So when you take your scan, you really want to evaluate it and make sure you see that shape of your scan body nice and clear. When we get to our bite registration, a lot of times the scan body can be in the way. It's too tall, right? That's okay. Take it out. You don't need it for the bite registration. Make sure you've scanned enough teeth and enough soft tissue in either direction around that implant area. So when you take out the scan body, you can capture the patient's proper bite. The scanner itself knows enough to align all the scans without the scan body being there. Okay, so make sure that the bite is correct. It's only helpful if it's captured correctly. So we have our restorative implant options. So what are they? We have our cement and screw retained restorations, right? We all know this. There's advantages to both and disadvantages to both. The biggest disadvantage I see to a screw retained restoration or a cement retained restoration is not only the cement, but it requires a little bit more space. Okay, so when we look at this, cement retained restorations, they have typically they'll have a custom abutment. If you're not doing custom abutments, I highly recommend that you do them because of just remaining cement. And I'll go over that in a second. But you want to make sure that you bring that margin. So you see that margin here, that middle red line is the margin up towards the top of the soft tissue. And that's simply for cement removal. Okay, in a screw retain restoration, it's all one piece. You can get away with having that margin a lot lower. And then, the reason you need all this other space is for resistant and retention form. So both of these are cemented together. It's just one is done in the laboratory, one is done in the mouth. And so you can get away with a slightly shorter restoration with screw retain restorations. Okay, for material considerations, we have our abutments and our crowns. Okay, so when we talk about abutment types, we have these stock versus abutments. So when we look at this, we want to make sure we pick nowadays. Most of us are doing this, but if you're not on this train, make sure you choose a custom abutment now. Most situations, stock abutments do not work. And they might look great for a few years, but over time, I guarantee you will have some cement and some issues down the road. So these custom abutments let you really put the margin exactly where you need it for optimal cement cleanup. Okay. We have abutment material consideration. So we have different abutments. We have titanium abutments that can be machined or polished. We have gold abutments, which are our old school UCLA or unit cast lab abutments. We have our zirconia abutments, and then there are some abutments out there made of PEEK. So our UCLA abutments are the ones we used to make. That was like what I grew up learning about too, right? We used to make these screw retain crowns based off of these UCLA abutments. They would have to cast them and wax them and cast them. And then we used to do this for all of our custom abutments as well. So now we've moved on and we're now milling all these abutments, right? So we have different options for milled abutments. We have our anodized abutment, which means it's just a titanium abutment that they're able to change the color of. So you can get kind of a warmer hue to it. You can request a pinker hue. So all of our impression components, remember they were different colors. Those are also anodized, right? They're just titanium materials that are anodized different shades. So we have a hybrid abutment, which is basically our zirconia plus a titanium base, and then our non-anodized. So those, just a little better look at what a hybrid is, right? So it's basically your cement titanium insert is cemented into this mesio structure, and that is customly designed. So it's, again, a custom abutment for you. There are limitations to milled, right? So usually these are made out of little blocks. So if for some reason the implant is more than 30 degrees off where you need it to be, they're going to have to do a UCLA old school cast abutment for you. So as long as it's not totally off, we can still utilize these milled custom abutments, which are much, much easier. As far as the crown material goes, we have aesthetic and full strength zirconia options. You can do glass ceramic pressed to zirconia. You can do glass ceramic pressed to metal. I tend to stay away from the right-hand side of the screen now. I'm much more of a monolithic kind of person, especially with implant restorations. That's just what I like. When you go into your cement retain restorations, if you have to do one, this is my recommendation as far as what goes with what. So the green check marks are what I typically like to use, but the check marks in general are what is acceptable that you could get away with, right? But for full strength and glass ceramic fused to metal, meaning you can't see through it, I'm using a regular titanium abutment. For something that has a little bit more transparency, I like to use those hybrid abutments. So you can absolutely use an anodized titanium if you wish. I find that when I do this, I like the overall look of the hybrid abutments under these aesthetic zirconias and my glass ceramic materials. How are we doing, Dr. Park?
We're good. How much more you got?
Got a little bit more to go through, some seating considerations.
Go ahead. Yeah, I mean, we've got a lot of questions, but I think people will be happy to hang out.
Okay. All right. I'll try to go as quickly as we can. So seating considerations I wanted to go through quickly. So when we seat, remember, you want to hand tighten the restoration. You want to take your radiograph, confirm that it's seated, and then you're going to torque it into place. Okay. So when I hand tighten 10 to 15 Newton centimeters, nothing more than that. If you think you can really hand tighten it down, don't. Just gently tighten it down till you feel like it's secure, and then take your x-ray to make sure that everything looks seated before you break a screw or do something that you shouldn't. Okay. Also really important, make sure you are torquing to the recommended torque values. Okay, so every system is different. Every component is different. Different size implants have different torque values. So just because it's within one system doesn't mean that every restorative component gets torqued the same way. So you have to look up. I've created little charts like this for the most common implant systems that we restore in our practice. So you can go ahead, you can take a screenshot of this if you want, or but I highly recommend making yourself little notes like this. I just tape them inside of each operatory, so they're easy referrals whenever we go to restore something. I'm not questioning what it is. All right. When we go to close up and deliver these restorations, right? So now we've torqued everything down and now we want to close it up. There are some recommendations for how we fill these channels now. And so the big thing is there's been a lot of studies on this, but if you are still using cotton rolls in your access channels, stop. The Board of Periodontists put this on their list of things that can cause peri-implantitis are the cotton rolls in the access channels. So stop doing that. If you open one of these up and take cotton rolls out, you'll know why. They smell horrendous. They look horrendous, right? So what they've found is PTFE tape is more recommended now. I'm not saying it's perfect, but it is better at keeping better physical barrier, keeping that bacteria at bay. So PTFE to cover the screw head, and then we can top it off with some composite resin. So when I'm looking at screw retain restorations themselves, there are some things I like to do to help hide that channel. And so the biggest game changer for me is using a blocker, right? So I have the tie insert in there or whatever that metal or substructure is. I want to block that off from vision. So I like to use a blocker to the height of the axis of the insert, right, to cover that metal on the inside. And then I'm going to go ahead and then I go through my various protocols depending on what the material is, right? So for something like zirconium oxide, like our Bruxer materials, I want to use an Ivoclean. This is caustic. So basically protect the patient as necessary, right? Put up all your barriers. I have my assistant with the high speed vac right there while I'm doing it, sucking up anything extra. I'm not going way down into the access channel. I really want to clean the zirconia above the tie base, right? So if there's zirconia above the tie base, that's the part that I want to make sure is nice and clean, full of saliva and primed for bonding. Okay. Then we place our nice clean Teflon tape in there to cover our screw head. And then we go ahead and do our bonding followed by our composite. If it's a temporary situation, I'm putting in a temporary for a while. I love to use a temporary material. Why have to pull out your drill, right, when you bring them back to take it off? So I use a Fermit. We have a bunch of Fermit here. I think Ivoclar has something similar. I can't think of the brand off the top of my head right now, but they have a similar product as well. So something temporary in there. I don't love to use PVS. I know a lot of people will use that temporarily. I find over time that just breaks down and becomes really challenging to take out. So things that are easy to take out. For cement retained prostheses, the biggest thing is just this is cement complications, right? We've all probably seen it. If you've ever had to take out an old restoration, no matter how well you've thought you've taken away the cement, there's always a little bit left over. There's tons of research out here just showing why cement is left over, right? There's been tons of studies like this. And the big thing is, if you have a subgingival margin, like in a stock abutment, you are going to leave residual cement behind. There are companies that have come out with cements that you can test radiographically. A lot of times they just take out the radio opacity component, so it looks like you kept it clean, and it's not actually. So be really, really cognizant of that. If you have to do a cement retained restoration, try really hard to keep up with it, with keeping it clean rather. So if you have to do it, I just want to review a handful of cement techniques and then I'll be finished here and we can get to questions. So the first thing is the copy abutment technique. If you're not familiar with this, just different things, because different things work best in different people's hands, right? So the copy abutment basically is an exact copy of the abutment. So to do this, it's a little bit of blue mousse or bite registration material. You take your crown and you squirt the material inside the crown, let it set, and then you pull the crown off and it should mimic what the abutment looks like. And so what this does, I put a little bit of Teflon tape in here I don't stretch it, but I put a little bit of Teflon tape in here to represent the cement barrier, the cement space. And then go ahead, fill in your blue bite reg, take it out, and then you will have a copy of that abutment. You actually put the cement into the crown and seat it on this copy abutment outside the mouth, and you'll see all that excess cement come away. You remove all the excess, and then whatever's left in the crown, you can move it around, make it nice and thin, and then seat it in the patient's mouth. And you should have a lot less excess to clean up. So it really helps limit the excess cement. Another option, if you don't like that, you can use a piece of rubber dam. So you can seat the rubber dam down and around at the time when you seat the abutment in the mouth. I've done this a handful of times, not my favorite technique. If the patient has not super tight tissue, then this works okay. If they have a thinner biotype that's more manipulative, this is okay to use. But for that really thick biotype tissue, this is a little bit of a challenge. But you can take a little square of rubber dam, place it in there, torque it, close your access hole, and then you go ahead and when you seat your restoration, you'll see all the excess cement come out around it. I did this kind of for an example, so it's a little more cement than I would recommend using, but just so you can kind of visually see what's going on there. Okay. The last technique, this is my favorite technique that I've used for throughout the years. Dr. Haas was actually one of my mentors. So I've been doing this since I was in dental school, but Teflon tape is like my favorite thing to use. If you've heard me speak, I always gush about it. Cheap, easy thing to use in dentistry. But for this technique, you're seating your abutment into the mouth, right? And then you're going to take a square of Teflon, take a square of Teflon tape and stretch it out. And just like a tent, you're going to tent it over the adjacent teeth, making sure you get on the buccal lingual surfaces nice and covered as shown here. And then you fill your crown, you seat it on, you pull everything off. Make sure you have a little cement still in the crown, and then you seat it back on. So all that excess cement comes out with the Teflon tape, and it doesn't go all over your soft tissue. Cleanup is really easy. It's much, much nicer. Another little tip is just using some like petroleum jelly. So be careful. These make these like little rockets in your fingers, right? Anytime you add that. So adding some petroleum jelly to the soft tissue really helps with cleanup, some of the adjacent teeth, and then around any area of the crown that you don't want the cement to stick is very, very helpful when it comes to cleanup. And so for that, I use like a micro brush to do this, or like a bend a brush, one of those to help kind of remove the excess cement and paint that petroleum jelly on there really, really helps. All right. And with that, big things here when you cement. So you want to avoid those stock abutments, right? We want that margin in an ideal situation. You want super gingival or equigingival margins are preferred. Okay. You want to optimize that retention resistance form. So just remember when we're choosing cement versus screw retain restorations, we want to pay attention to the space that we have. Again, this is hopefully coming down as we do this more and more in that treatment planning phase before the implants in, then after, right? You want to control the volume of the cement that you have. And then different recommendations I have for cements. People always ask that. So for kind of a more temporary situation, I find these don't last, especially with single units, for very long. But if you want to temporize something for a little while, zinc oxide eugenol is really nice. It's antibacterial. You can see it on an x-ray if you need to check it out. So I do like to use that for a temporary situation. For a more long-term situation, if it's in a non-aesthetic region and I'm using like a full strength or something where shade isn't an issue, Ceramere is really nice. It's just that bright white color. So just be aware of that. If you're doing it in anterior, it's very easy to remove the cement, which is really nice. If you're in the anterior, then, I don't love to use it, but I've used some resin cements in the anterior. You just have to be really careful because they have like HEMA in it, which can cause some issues with fibroblasts and cause some issues with the soft tissue. So again, just make sure you follow all these principles to keep kind of that soft tissue in as big health as you can and keep excess cement from getting underneath the tissue. All right. With that, I will take some questions.
Great lecture. I do have to tell you that you broke my heart by not recommending zinc phosphate cement, but I'll get over it.
I mean, you can. We don't have any here.
It's just
Not
very
anymore.
easy to clean up. I like it.
It is actually very easy to clean up.
Okay, here let's try to get through some questions here. Okay, on open tray impression copings, do you always take a radiograph?
I do. So any impression coping that I put in the mouth that I'm going to take an impression on, I always take an x-ray of it just to make sure that it's seated. I will say the one caveat to that is if I can visually see it. So if I can see the connection of the coping to the implant, if there's no soft tissue, like if I have some recession or there's a multi-unit abutment in there, this is getting into multiple implants, but if I have an intermediary abutment that brings the level above the tissue, then I don't bother taking x-rays. But if I
Okay, so if
can't
you can't
visualize
directly
it,
visualize it, you take
yeah,
the radiograph. Got it.
always.
Okay. Couple people had these same questions. So you showed how you create a path of insertion, and you're doing sort of that enameloplasty and approximately. Um,
Yes.
doesn't that create a situation more prone to bacterial accumulation, more caries prone? And then part two of that is how do you smooth that over and polish it after you do
Yeah.
that?
No, great question. So it really depends on how much tooth structure you have to take away. Most of the time, it's very limited. So it's going to be similar to creating like a guide plane for, like I said, like an RPD. You don't need to get overly aggressive with this. The point is, I want to get rid of any pinpoint contact and make more of a broad contact. So the examples I gave you are very extreme examples, more for visualization. But if you have something that is extreme like that, a lot of times I'm adding composite to those undercut areas. So I'm recontouring the adjacent teeth a little bit, almost like a class 5 situation, right? I'm going in there and just recontouring the adjacent teeth to build up a little bit. And that's really more of what I'm doing. As far as any tooth structure that I do have to take away, I just go through and polish like I would polish my composite. So I'm going through with a fine diamond burr typically to initially do those. And then I'm going to go ahead and go through my polishing wheel. So whatever wheels you have in your office, if you have like Solflex discs, those work really well, which we love to use in our office. You can use some composite finishing burrs if you want, but just get that surface nice and smooth. But yeah, I'm not taking away like through the enamel. That is a big no-no.
Okay, you showed two really great charts. One was that I think it was by Todd Scheinbaum of all the implant abutment connections and what they're supposed to
Yeah.
look like and when they're seated. Is that a chart that we can share, or is it a reference you can provide to our attendees?
It's a reference. I took it from his, here, let me see if I can pull it up for a second. I did take it from his textbook. So I don't know about sharing it too much, but I did put the reference on there. The image is from his implant prosthesis textbook. And that's his name on the bottom there.
Okay, so it's copyrighted material. We can't share it, but
Right.
but that's where it is.
Yeah,
Okay.
that is where it is.
Okay. And then the torque value chart, I think you put that together, right?
I did. That's my chart. That I can and will happily share with anyone that would like that.
Yeah,
But
we'll have it go out with the emails.
Yeah, and just remember this is Glidewell's specific implant system. So this is Glidewell's Han tapered implant system. So if you do use the system, feel free to use this chart. But if you use other systems in your office, it's a great template to make charts for other systems.
Okay, great. And the product you showed for lip retraction, I think you said it was Optragate.
Yes, that is an Optragate. We use those a lot here.
Okay, and those are from Ivoclar.
Those are from
for
Ivoclar.
People that want this. Okay. Now, if you find the necessity to do bone profiling, to remove bone from the cover screw or bone from around the collar of the implant, do you take the impression that same day, or do you reschedule to allow tissue healing?
So I'm going to say that depends. So I used to always allow tissue healing.
You're not the lawyer. You're not supposed to say.
So I will say I used to always allow for tissue healing, and now I don't anymore. So it just really depends on where we are in the mouth. So if it's in a non-aesthetic zone, I will take the impression the same day. If it is in an aesthetic zone in the smile region, I am 100% going to wait and make sure that soft tissue heals the way I want it to heal before I go ahead and take my final impression. If it's an impression for, say, a provisional that I want to make in the anterior, then I will take the impression the same day because I know I can recontour and play with the provisional a little bit when it comes back.
Very good. Very good. There's good questions still coming in. Um, Okay, so can you walk us through the digital RX? There's a lot of
Yes.
confusion of when do I have to use the company's scan body, when do I have to use the lab scan body, and then how do I fill out the digital RX?
Absolutely. Okay. So the gist of it is when you are whatever lab you guys use. So if you are Glidewell customers, then I would call the lab themselves, call the implant department, and see what they are recommending. So every lab, especially in the digital world, it really just depends on what libraries they have in their system. And so, like for example, Glidewell makes a lot of scan bodies for various companies, and they prefer to use their own scan bodies. I think there are a couple companies that they have exceptions to that rule for. So again, I would just contact your laboratory themselves and ask specifically for that system. Do you have a scan body that I need to purchase from you, or can I purchase directly from the manufacturer? And do you have that library if I do so? So that's the biggest thing, is just making sure they have the compatible libraries. As far as filling out an RX, so the big things that are a little challenging with a lot of our digital RXs is we don't have the boxes to check, right? So you need to make sure you're giving them the right information. So the biggest things are hopefully your scanner has integrated whatever implant systems you are scanning and using into the digital RX. So a lot of scanners, you have the ability of basically selecting from a drop down menu what implant system, implant manufacturer you're using, the size, the platform diameter, all the information you would need. You can select all that just like you would a traditional RX. Sometimes the companies, the scanning companies don't have that, and you need to put that information in the note section. So in the note section, I'll always make sure you want to include what implant you're restoring, right? So that's a very important component. You want to include the diameter or the platform diameter of the implant that you're restoring. And then the basic things, right? So not only the implant information, but now we need the restorative information. So what type of restoration you ultimately want. Do you really want to shoot for a screw retain restoration, or do you want a custom abutment? What type of custom abutment do you want? What material do you want? What shade do you want? So there's about 5 or 6 items I'm always including. We don't need long sentences, but just so basically, say I'm restoring a Han implant. I'm going to say, is the Han tapered implant? It's 4.3 diameter. I would like a screw retained Bruxer aesthetic crown, shade A2, right? And that is basically my RX for that. But those are all the basic information that you need to include on a digital RX.
Very good. Very
And
good.
you can call your scanning company and they can help to import a lot of that information into your scanner too. For the most part, a lot of the companies will do that.
Excellent. Excellent. And we did have a suggestion for you to come back and talk about implant provisionals. I think that's a great idea.
Okay.
And thank you, Dr. Manalili, for your routinely excellent presentation. There
Oh,
was so
thank
much
you.
good practical advice there. I think everybody's going to benefit from that right away. So thank you, Dr. Manalili. Thanks, everyone, for joining us today. And thanks for the panel for all of their insights. And be sure to
Thank
join
you.
us next Friday when our guest speaker will be Dr. Shankar Iyer. And he's going to talk about biomaterials and biomechanics, understanding the fundamental concepts for implant treatment planning. So don't miss that. Be sure to join us. And thanks to all of you. Great to see you, and have a good week. And we'll see you next week. And thank you, Dr. Manalili.
Thank you so much.